So what are the leading treatment options for patients with low or negative PDL1 expression in advanced non-small cell lung cancer? So the leading options at this time are platinum pemetrexed plus pembrolizumab, which is a PD-1 antibody, and carboplatin paclitaxel, atezolizumab, and bevacizumab. I'm going to go through the data for these two regimens with you. So the KEYNOTE-042 trial was a double-blind phase 3 trial of over 600 patients. This trial excluded patients with EGFR or ALK mutations and was a frontline treatment trial. So patients had to not have received any prior therapy. Patients were randomized to receive either platinum pemetrexed or platinum pemetrexed with the addition of pembrolizumab, given at a dose of 200 milligrams IV every 3 weeks. The overall survival at 12 months favored those patients receiving pembrolizumab, so 69% for those patients receiving pembrolizumab versus 49% for those patients receiving placebo. On a subgroup analysis, it appeared that patients benefited with the addition of receiving pembrolizumab regardless of PDL1 expression level. Response rates also favored those patients receiving pembrolizumab. Response rate of 47.6 in those patients receiving pembro versus 18.9% in the placebo arm. It was found that the response rates were higher across all subgroups of PDL1 expression, with the greatest between group difference in those patients considered to have high expression of PDL1, which was defined as greater than or equal to 50%. Disease control rate and median progression-free survival also favored those patients receiving pembrolizumab. It's important to point out that the addition of pembrolizumab really did not result in an increase in grade 3 or higher adverse events, though there was a higher rate of immune-mediated adverse events, as you would imagine, with the pembrolizumab arm. About 22.7% of patients receiving pembrolizumab developed an autoimmune-related adverse event versus close to 12% in the placebo arm. So based upon this KEYNOTE data, the FDA did approve this combination in May of 2017. This has really altered our treatment paradigm for lung cancer for our patients with metastatic non-squamous non-small cell lung cancer. Moving on to the IMpower 150 trial, this was also a double-blind phase 3 trial involving patients with metastatic non-squamous non-small cell lung cancer. This trial did include patients with EGFR and ALK mutations, provided that they had progressed on prior TKI or targeted therapy. So again, this was a first-line trial, so no prior treatment was allowed. Patients were randomized to one of 3 different treatment arms in this trial. So the standard treatment arm was considered to be the carboplatin paclitaxel plus bevacizumab arm. So bevacizumab is an anti-VEGF antibody that's been approved in combination with chemotherapy. The next arm was carboplatin paclitaxel with atezolizumab, which is a PDL1 antibody. And the third treatment arm was the 4-drug regimen of carboplatin paclitaxel, bevacizumab, and atezolizumab. The median overall survival favored those patients receiving the 4-drug regimen of carboplatin, paclitaxel, bevacizumab, and atezolizumab. Response rates were also higher in those patients receiving the atezolizumab, and duration of response and median progression-free survival also favored those patients receiving the combination of carboplatin, paclitaxel, bevacizumab, and atezolizumab. And there were no new safety signals seen in this trial. So it was based upon this data from the IMpower 150 trial that the FDA did approve this 4-drug regimen in December of 2018. So we now have these true treatment options for our patients with metastatic non-small cell lung cancer. How do we choose one over the other? In practical terms, many of us are using the platinum pemetrexed plus pembrolizumab regimen for our non-squamous patients over the 4-drug regimen because it is easier to administer. The pemetrexed is a much shorter infusion. We also know that paclitaxel in many patients will lead to hair loss and neuropathy, and so pemetrexed just tends to be preferable to the paclitaxel. Of course, these regimens have not been compared head-to-head, so it's difficult for us to say that one is superior to the other. Interestingly, the Empower 150 trial did include patients with EGFR and ALK mutations, whereas the Keynote 042 trial actually excluded those patients. So where I see a role for this 4-drug regimen may be in those patients with EGFR or ALK mutations who have disease progression on prior TKI therapy. Perhaps these are the patients that we would consider treating with this more aggressive treatment regimen of carboplatin, paclitaxel, bevacizumab, and atezolizumab. There's felt to be potential synergism between the anti-VEGF antibody and the PDL1 antibody that could result in improved treatment outcomes. And so I think it warrants a discussion with the patient. And certainly we do have now data for these specific patients with EGFR and ALK mutations who progressed on prior TKI therapy with the Empower 150 trial. So I think it is a potential option for these patients. I'll end with mentioning the recent data from the Checkmate 227 trial. I won't go into it in great detail, only to say that we do have a recent publication evaluating the role of nivolumab with ipilimumab. So nivolumab is a PD-1 antibody. And in this Checkmate 227 study, it was studied in combination with ipilimumab, which is a CTLA-4 antibody, in comparison to chemotherapy. And what this study found was that there was a survival benefit in those patients receiving the combination of nivolumab and ipilimumab. We will have to see where this is going to be falling into place in the clinical setting while we are waiting for FDA approval of this regimen. But this may be another potential option for our patients, particularly those patients who wish not to receive traditional IV cytotoxic chemotherapy as part of their frontline treatment.